This time in the Medicine of the Week, we will discuss a category of medication instead of an individual drug, namely the immune checkpoint inhibitors. This time we will discuss 7 monoclonal antibodies within one video, since they all have similar mechanisms of action, namely the CTLA-4 inhibitor ipilimumab, the PD-1 inhibitors cemiplimab, nivolumab, and pembrolizumab, and the PD-L1 inhibitors atezolizumab, avelumab, and durvalumab. These agents are used in oncology to boost the immune response against the cancer. There are different mechanisms in our immune system that on the one hand can activate immune reactivity, or on the other hand suppress immune reactivity in order to prevent those reactions from getting out of hand. The immune checkpoint inhibitors are novel therapeutics. A number of these have recently become standard treatment for various types of cancers. They are used as mono or combination therapy in the treatment of various cancers at specific stages of progression, including in the metastatic setting. At the time of recording this video, there are 7 approved immune checkpoint inhibitors for the treatment of multiple types of cancers. There are too many indications to go through them individually, and as the field is very dynamic, other indications with these drugs are to be expected. For the current state of affairs, I would like to refer you to your own national pharmacology guidelines. The T cells in our body are basically programmed to detect and eliminate cancer cells. All of these immune checkpoint inhibitors activate the immune system to better clear out the cancer cells. We can group the immune checkpoint inhibitors by their target. I will first discuss the mechanism of action of ipilimumab, which is a monoclonal antibody that binds to CTLA-4. T-cell activation takes place, among other things, through the interaction of ligand B7 on the antigen-presenting cells and the receptor CD28 on the T-cell. CTLA-4 is a checkpoint molecule on the T-cell that diverts the interaction with B7 from CD28, preventing T-cell activation, which in turn contributes to T-cell inhibition. So, how does ipilimumab fit into this story? Ipilimumab binds to CTLA-4, counteracting immune suppression of the T-cell, contributing to T-cell activation and ultimately better recognition and killing of cancer cells. I will now discuss the mechanism of action of the PD-1 and PD-L1 inhibitors. Some cancer cells express the ligands PD-L1 and PD-L2, which upon interaction with the PD-1 receptor on T cells leads to immune suppression. The cancer cell tries to, as it were, escape the immune system by expressing PD-L1 and PD-L2. The immune checkpoint inhibitors cemiplimab, nivolumab, and pembrolizumab are monoclonal antibodies that bind to PD-1, while atezolizumab, avelumab, and durvalumab are monoclonal antibodies that bind PD-L1. The effect of these 6 agents is to prevent the interaction between PD-1 and PD-L1, counteracting immune suppression of the T-cell, which in turn contributes to T-cell activation and ultimately better recognition and killing of cancer cells. These immune checkpoint inhibitors are monoclonal antibodies that are all administered intravenously. Infusion reactions sometimes occur, after which subsequent infusions may require pre-medication with antipyretics and antihistamines to minimize the risk of subsequent infusion reactions. Immunotherapy is maximally given for up to 2 years, and currently studies are being done on the duration of treatment, with the idea that shorter treatments may have the same effect. And in a study context with response, these drugs are sometimes stopped earlier. Dose adjustments of these immune checkpoint inhibitors is not necessary in mild to moderate renal impairment, nor in mild hepatic impairment. An important point regarding immune checkpoint inhibitors is that long-lasting responses are seen with these drugs in previously incurable diseases, with some oncologists almost daring to use the word cure. This graph shows the survival of patients with metastatic melanoma after treatment with ipilimumab in gray, nivolumab in blue, and nivolumab plus ipilimumab combination therapy in green. Long-lasting responses are seen in approximately half of patients with this combination therapy. And because of these spectacular developments, the Nobel Prize in Medicine was awarded in 2018 to the pioneers of immunotherapy for cancer. A disadvantage of immune checkpoint inhibitors is that the activation of the immune system can also lead to autoimmune reactions, which in theory can damage any organ. This picture shows an overview of these side effects. Examples are pneumonitis, hepatitis, myocarditis, and encephalitis, and many more. What is special about these side effects is that they can occur up to months after treatment. And depending on the severity of the side effects, treatment may need to be discontinued. Treatments with corticosteroids can sometimes calm these reactions. Treatments with immune checkpoint inhibitors are challenging because the oncologist needs to find a balance between treating the cancer on the one hand and preventing autoimmune reactions on the other. These new drugs come with a high cost, and as they are increasingly used in oncology, more money will be spent on them. In 2021, $24 billion were spent worldwide, and it is expected to reach $46 billion in 2026. Due to the high costs, these immune checkpoint inhibitors are not equally accessible worldwide. As a result, research is also being done into more cost-effective dosing schedules and shorter treatment durations. To summarize, these agents are called immune checkpoint inhibitors and reactivate the immune system. These agents are monoclonal antibodies directed against CTLA-4, PD-1, or PD-L1. These agents are important in oncology, where the list of indications is likely to continue to grow. An important disadvantage of immune checkpoint inhibitors is that very serious autoimmune reactions can occur.